like to welcome Assemblyman Jim Wood. Assemblyman Jim Wood is chair of the Health Committee. He's been in the legislature since he was elected in 2014. Represents a very large district from Santa Rosa all the way up to the Oregon state line. A very large district along the coast all the way, a beautiful district, I must say. I've driven through it. And if there's anyone in the legislature who knows the health issues, it's Assemblyman Wood. So welcome. We want to hear a little bit about what the priorities are, what the successes have been, what the challenges are for the immediate future.
Great.
Yeah.
Well, good morning. Thank you, everyone, for the opportunity to be here. It's really an honor to open up your conference today, and it's actually great to see people in the flesh, although Vern must have better eyesight than me because I can't see your eyes. So I think he might be lying, but that's okay. But we don't have the Zoom thing today, which is a real treat, thank goodness. So you have nearly 60 speakers and experts on your agenda covering an amazing range of healthcare topics. After you listen and engage with the speakers, I hope you're able to walk away with a sense of optimism, even while absorbing all the challenges and complexities we face in healthcare. Having said that, I'll also feel better if I'm not the only one who is sometimes overwhelmed. I read my introduction in your program, and it says that I will speak to you about what's on the top of mind in healthcare and what I predict for the future of California healthcare policy. I'll respond with a quote attributed to Yogi Berra. It's tough to make predictions, especially about the future. And haven't we been reminded of that the past 2 years? So, yeah. On the other hand, we all know very well what's on the minds of the public when it comes to healthcare. California Healthcare Foundation National Opinion Research Center Health Policy Survey conducted in the fourth quarter of last year reports that 83% of Californians are concerned about healthcare costs. 53% want more affordable health care and rated it as an extremely important priority. 49% of Californians have skipped or postponed some type of health care in the last 12 months due to cost. Of those, 47% report that their condition worsened as a result. And 59% of Californians believe that the healthcare system treats people unfairly based on racial or ethnic background. California is unique in many ways. Our size, demographics, and geography pose many challenges. For example, I practiced dentistry in a rural California for almost 30 years. Actually, when I heard your sponsors, I thought it was a dental conference. You know, we got 3M and Western Dental and, you know, the other companies. But I understand the challenges of accessing healthcare in rural California. My patients reflected a diverse population in Northern California, some with dental coverage, some without, young, older, those who could pay, and those who could not. Those who didn't speak English, and those who needed the assistance of Medi-Cal or the Denti-Cal program, and I treated them all. Bottom line is, healthcare is too expensive and its growth rate is unsustainable. Health equity is another challenge. We need options to allow older people to stay in their homes longer. Why can't we seem to control the price of prescription drugs? We need better access to mental health care services. And do we have the workforce we need now and in the future? No, we do not. Are we minimizing the capabilities of our professional healthcare workforce? In some cases, yes, I believe we are. If a patient is treated one way and it costs this much, what was the outcome? Is one type of treatment more effective than another? Does a less expensive treatment necessarily mean a less effective outcome? I don't think we can move forward based on that assumption or any other assumption. Many of the challenges continue because we lack the data to help us understand why, what, and who are the healthcare drivers, the drivers for the cost of healthcare. Once we have that data, we can begin to make meaningful and significant changes. Right now, the status of the overall health of communities drives utilization, which is unpredictable. Many things contribute to poor health in our populations, including lack of access to care, housing, healthy food, and transportation. Once we improve the system and more people receive the care they need earlier, utilization becomes much more predictable and costs can be contained. What we can all agree on, I'm sure, is the answers are not simple. I had the honor of being appointed the chair of the Assembly Health Committee in early 2016, and spent my legislative career trying to find ways to make quality health care and access affordable and accessible to every Californian. That journey, among other things, included many, many health committee hearings on hundreds, possibly even thousands of bills by now, 33 informational hearings, and I've either chaired or co-chaired on health issues. During that time, I dove deep into healthcare policy, and I continue that deep dive. I've questioned and taken on individually many of the cost drivers in healthcare: prescription drugs, hospitals, health insurers, skilled nursing facilities, pharmacy benefit managers, other healthcare service providers, even my own healthcare provider community. I'm sure there are posters of me with a big circle and a slash through it in many places out there, but I don't do it lightly, and I do it for the benefit of my constituents and for the people of California. I've authored successful legislation or effected policy changes on eliminating surprise billing in California, creating an all-payer claims database, which will be up and operational next year, regulating PBMs so we can open the black box, so to speak, on their business model, more oversight of for-profit skilled nursing facilities and their use of related parties to boost profits instead of improve patient care, requiring the state to study the feasibility of a public option, creating a Healthy California for All Commission, that was my bill, to develop a plan for advancing progress toward achieving a healthcare delivery system through a unified publicly financed system, including, but not limited to, the possibility of single payer at some point. Increasing subsidies provided through Covered California, preventing pay-for-delay agreements between pharmaceutical companies and generic manufacturers that delay affordable generic drug introductions, and allowing qualified nurse practitioners to practice within their scope without the supervision of a physician. And I continue to work on creating more oversight of mergers and acquisitions in healthcare. We know that these mergers and contracting methods have many times, maybe even most times, not resulted in lower costs or greater quality to patients. That's the wrong direction, and these transactions need more scrutiny by our Attorney General. Dealing with the individual cost drivers has not been as successful as I'd hoped. The impacts have been limited by federal law, as was the case with surprise billing. Others have resulted in lawsuits. Actually, as a badge of honor, some of the best work I've ever done immediately results in a lawsuit. And we prevailed most of the time. As we slowly move through COVID, everything has slowed down. The legal process has slowed down as well. So for the past 2 years, I've been working on a more comprehensive approach. In early 2021, I introduced AB 1130 to create the Office of Healthcare Affordability, or OCA as we call it. We're good at that in government. We've got abbreviations for everything. I still don't know them all. This office would collect and analyze the healthcare market for cost drivers and trends, so that we can develop data-informed policies, ultimately cost targets, with the goal of lowering and controlling costs to provide quality and affordable healthcare to all Californians. I've been working closely with Governor Newsom's administration, as well as engaging my colleagues in both the Assembly and the Senate, and discussions have included a wide range of stakeholders. We need to include and collect data from all healthcare entities that are dominant enough in an area where they have a significant impact on pricing. That includes healthcare service plans, health insurers, hospitals, and physician organizations. Unless everybody is in, we won't have the data to establish meaningful targets. The office would have a healthcare affordability board that would evaluate information and recommendations from OCA, and unlike a few other states that have a similar office, this board would have the authority to enforce established cost targets. The board would evaluate information and recommendations from OCA to establish an overall statewide cost target for increases per capita, total healthcare spending, and specific targets for different sectors of healthcare, including payers, providers, the insurance market, and the line of business, as well as geographic region, by geographic region. The target would be a percentage and could be based on established economic or population-based measures. The board would approve the methodology for setting cost targets developed by OCA. The board would also establish the scope and range of administrative penalties assessed by OCA, as well as factors for consideration when assessing penalties. The goal is not to penalize people. The goal is to change behavior. I hope that this is a velvet hammer and not meant to be, a sharp stick. It's firmly believed there is enough waste and inefficiency in healthcare that if we just paid attention to some of that, we could actually begin to bend the cost curve. The unsustainability of the rising healthcare costs is shocking. On average, since I've been in office, it's rising at twice the rate of inflation. If that happens this year with inflation close to 7+%, it's going to be catastrophic and it continue on. Addressing healthcare growth is not easy, but it's critically important to the health and economic security of Americans across the country. California is and will remain a leader in that fight. So I'd like to thank the State of Reform here for convening us all together here. I'll stop talking, I'll let Vern ask me some questions, and I'm happy to take questions from the audience.
Well, thank you, Assemblyman. I would like to actually get your questions right from the very beginning. So if there are a couple microphones that are coming around, and so if you have a question, if you could just raise your hand, a microphone will come to you. So is there a hand? Is there a hand?
I've shocked everybody. I didn't know what to say.
It's early in the morning. I see a hand right there, and so there's a microphone right there for you. Yes.
Hi, good morning. I was wondering if you could give your perspective on the role of community health workers moving forward.
Community health workers, as in people working community health clinics, or just broader?
I think it's with the view to the new CalAIM enhanced care management and community services, or in lieu of services.
That might be a really good question for that lady right there. Michelle Baass is going to be speaking, but look, I think CalAIM is going to be a huge transformation for the Medi-Cal system, and we're happy to have been working closely with the administration on that in the last year, and with Director Baass as well. We need a larger workforce. There's no question about that, and as we transition into CalAIM, I think you're going to see a broader way of which we engage workers and workforce. So. Hard to be specific at this point. I think it's an evolution, but I think the critical component of that is we are facing significant workforce shortages, and we've got to address that if we're going to be successful.
Yeah, I think the essence of that, if I can take the liberty of doing that, community health workers are non-medically trained.
Correct.
And so I think part of the initiative here is to bring to healthcare persons who address those other things which are not medical in nature, which is what a community health worker can.
Yeah, and I think what I'd like to see there is in that role more coordination of someone who can be that coordinator to help people. Let me give you an example of a program in my district. It's the Cancer Resource Center in Mendocino County. It's a grassroots organization. And they have people that work in this organization to help people navigate the medical system when they develop cancer. And so they coordinate appointments, and they're there to support people. And it's an incredible model, and what it does, not only emotional support, family support, transportation, and these are the kinds of things that are really, really valuable. And I can foresee that happening in a variety of different ways. But for me, there's so many silos in healthcare. There's so many, and to have a way to coordinate care is only going to be beneficial to everyone. And I believe, really honestly, that is a big part of what I hope CalAIM will help us with in the future.
Yeah, great. Another question.
Over here, or?
Oh, okay, over here, and then there's
hi there.
and then if you can, yes, go ahead.
Assemblymember Wood, as you wrapped up your comments about the Office of Healthcare Affordability, you said you're hoping this will change behavior, and you mentioned fraud and waste. So are you hoping to get at what people term overtreatment, or so? What do you mean by change behavior, and who needs to do the changing?
Well, I think it's about, I can't tell you how many times over the years, I would have a medical test and I go to another office and they'd want to order the same test. Why are we doing that? Why are we doing that kind of thing? What is the value of doing something, retesting something that was, a couple of weeks earlier? That's a waste to the system. Is there low value care? I think that's low value care. What is the outcome for that? So, not in every case it's different. It's not always the same. And I think that there is, if people have to pay more attention to the things that they're asking patients to do, they may not order some of those extra tests. They may not be necessary. I'm not in any way trying to hamper quality of care. A part of it is I want people to think about what they're doing. Let me give you an example of what I'm concerned about. In San Diego County, this comes from California Healthcare Foundation stuff, so I didn't just dream this up. So in San Diego County, the cost to deliver care is 20% less than it is in Shasta County, on the other end of the state. Why? 20% less, and they get better outcomes. We need to learn what's going on in Shasta County and what's going on in San Diego County and marry those two so that we can get a better quality of care throughout the state. And there's probably a number of issues that are leading to that, but why? And right now, we don't have the data to really understand that, and that's really what it is. I am very, very data-driven. That's why I was so passionate about getting the all-payer claims database up. That will be foundational to what the Office of Healthcare Affordability does. And so until we understand how we're spending our healthcare dollars and what the outcomes are, we can't really improve the system the way I think we can in California. And we should be leaders on this.
We have time for one or two more questions. We had one here and one there.
Hi, Assemblyman. I was wondering, particularly with your perspective of coming from a rural county, I know a lot of, particularly rural counties, they just don't have the providers to even get started into the system, let alone get the tests and deal with those issues. So do you have suggestions on what potential solutions there might be for, like I said, especially those rural counties, in getting them access to the system?
It is, my district is largely rural. I have the largest district of any assembly member, any Democrat in the assembly. It's bigger than some states. It takes me 7 hours to get from one end to the other by driving. I can't fly anywhere predictably because there aren't any flights. The largest city outside of the city of Santa Rosa has 27,000 people. I have 2 of those. And then it goes off from there. So we have problems, we have challenges with workforce, we have challenges with transportation, we have challenges with coordination of care, specialty care. We have lousy broadband. I have the lowest broadband adoption rate in the state. So telemedicine is a challenge. And so for me, my philosophy has been, if it's good for my rural district, it's going to be good for California. And so I keep hammering away at these things. The interesting thing about rural communities, and anybody who's from a rural community here knows this, if you give us the resources on a per capita basis of what we should be due, and give us some flexibility, we can move mountains. We can do incredible things. But so many times, the resources and the technical things are so difficult to navigate that some of my rural counties can't even access them. So I'm constantly, give us flexibility, give us the ability, give us our fair share, and we'll be able to accomplish a lot. And that is a almost seismic shift that in my 8th year, we still struggle with that. Every time something comes up, I'm kind of like, can we have some flexibility? Can we make sure we get our portion of it? Put it in perspective, 27 members of the Assembly represent part of Los Angeles County. I represent 5 counties. How do you think my voice gets heard? Not often. And so I continue to beat the drum and push for the things that I know. Like I said, if it's good for my district, it's going to be good for California.
We have some great questions out there. We are out of time. One last quick question, and we need to save time for Michelle Baass. So yes, one quick.
Oh.
Yeah. Quick.
I'm sorry. I came all the way from Maui. I'm vice president of the Maui County Medical Society, sit on many committees. This is my concern. I'm also licensed in California. I was trained at the UC system. My concern is all medical schools have not made plans to increase positions for future doctors. That's one of many concerns for me, but that's my priority. Please, Assemblyman Jim Wood, thank you for allowing me to speak. Were you aware of this?
Yes, I've been aware of that for a long time, and it's a huge challenge. We also haven't been able to expand nursing programs, CNA programs, nurse practitioner programs. It is a huge issue for us across the spectrum. And it takes an investment, and it's going to take a commitment. And if we're going to ever be able to really address this, and it's a huge challenge for us. So I am completely aware of it, and we're doing everything we can on our end. But we can't control what an individual university might do. Some of them are private, some of them are state, but it is a resources issue. And so we keep beating the drum on access, on workforce, and we'll just keep hammering away, and hopefully at some point we'll get there.
Assemblyman, we are out of time, like the 6 o'clock news.
Yeah,
when it's
right.
time, it's time. And so we're going to have to
Thank you.
Stop right there. But thank you so
Yeah, my
much for
pleasure.
joining us today.
Thank you. Have a great day. Thanks.
Thank you. That was awesome.
Thanks.
Great. We're joined now by Michelle Baass. Michelle, why don't you go ahead to the podium. Michelle has been the director of the Department of Healthcare Services for the last 6 months. And so it's been a quick bit of orientation to the new department. Been with the executive branch for about 5 years, and before that, a long career on the legislative side as well. So you understand both branches of government. But welcome so much. We really look forward to hearing, what is the department doing now? How are you moving forward? How are you addressing all of these challenges in this complex healthcare world that we have here in California? Yeah.
Great, thank you very much, and good morning. Thank you for the opportunity to be here today and for the invitation. Our 10-year vision for Medi-Cal is that people served by our program should have longer, healthier, happier lives in a whole system, person-centered, and population health approach. Healthcare services are only one element of supporting people to have better health and better health outcomes. Services in our vision would be tailored to the individual, as well as to communities and individuals, groups of people based on their unique needs and what matters to them, as well as quality, equity, and safety outcomes. We know we need to partner with our communities, our community-based organizations, our members, our counties, public health, in addition to many, many stakeholders, in addition to the healthcare delivery system, to support and anticipate health needs, prevent illness, and reduce the impact of poor health outcomes to achieve our vision. We, as the department, want to operate more efficiently, effectively for our 14.5 million beneficiaries and the people of California as a whole. 1 in 3 Californians are enrolled in Medi-Cal, with more than 65% of our enrollees identifying as people of color. Medi-Cal covers 50% of births in California, with about 2/3 of children enrolled in Medi-Cal identifying as Latino or Black. More than 2 in 3 patient stays in long-term care facilities in California are covered by Medi-Cal. The initiatives I will discuss today are our path forward toward implementing this vision. I will highlight our statewide managed care procurement and new Medi-Cal managed care contract, our ambitious quality strategy, and first we'll start with our sweeping Medi-Cal reform, CalAIM. CalAIM is our multi-year initiative to improve health outcomes and equity through delivery system transformation and payment reform. The primary focuses of CalAIM are to reduce the complexity of navigating across delivery systems, as Dr. Wood just mentioned, and to address the whole person when providing health care. We want to meet people where they are, address social drivers of health, and break down the walls of health care. CalAIM moves Medi-Cal towards a population health approach that prioritizes prevention, whole person care, and extends supports and services that are beyond hospitals and healthcare settings directly into California's communities. CalAIM offers our beneficiaries coordinated and equitable access to services that address physical, behavioral, oral, long-term care, and developmental needs through their lives from birth to dignified end of life. In January, we launched the Enhanced Care Management, a new statewide benefit in the managed care delivery system. ECM is intended to address the clinical and non-clinical needs of our members who have the most intensive care coordination needs and health-related services. In addition, to make it easier to get the right care at the right time, members will have connections to community supports to meet their social needs. A big challenge we face in CalAIM implementation is engaging with new provider types who have not traditionally been part of the Medi-Cal space. Those offering housing and navigation support services, caregiver respite, home modifications, personal homemaker services, sobering center services, for examples. We expect the adoption of these services to expand further over the next several years, and to be successful, we know we must strengthen our relationships with these providers and provide supports to support them. CalAIM also introduces some new behavioral health policies to better meet the needs of our Medi-Cal beneficiaries with substance use disorder and mental health conditions. Individuals will now receive behavioral health services without a diagnosis during the assessment period. We also simplified the criteria for specialty mental health services so that children experiencing significant trauma, such as homelessness or involvement in the child welfare system, have automatic access to specialty mental health services. We've created a no wrong door policy, so individuals do not need to disrupt their trusted relationships with providers in one system when they may need to receive care in another. And then as part of our CalAIM waiver, we also reauthorize our drug Medi-Cal organized delivery service, which is in 37 counties, and are piloting coverage of the contingency management benefit and have added peer support services. We've removed limitations on residential treatment and have expanded access to recovery services. We are now focusing for our readiness on some of the CalAIM initiatives that are forthcoming. This includes the integration of long-term services and supports in the Medi-Cal Managed Care program and the enrollment of dual eligibles into managed care. Population health management, which is one of the cornerstones of CalAIM, really creates some requirements on our Medi-Cal managed care plans to shift from a reactive, episodic approach to an upstream, preventive approach. And I will talk a little bit more about our population health management strategy in a minute. And then our justice package. We are establishing some new requirements for our prisons, jails, and youth correctional facilities to expand Medi-Cal eligibility enrollment, to provide a select set of Medi-Cal benefits to certain eligible individuals up to 90 days prior to release, and to facilitate warm handoffs to our county behavioral health departments and Medi-Cal managed care plans. I think our CalAIM justice package is one of our biggest equity levers that we are proposing with this initiative. Now, moving on to our quality strategy and population health management approach. As we expand coverage to more and more individuals, we want to ensure our coverage results in quality care and better health outcomes for all communities. Our comprehensive quality strategy goals aim to improve the member experience by engaging them directly in Medi-Cal policy. We want to intervene upstream to keep families and communities healthy via prevention. We want to provide patient-centered outcome chronic disease management and provide whole person care for high-risk populations by addressing social drivers of health. Historically, healthcare activities have largely been reactive, responding to visits, to falls, to hospitalizations, as some type of event has occurred. A core pillar of our strategy is to be proactive, to address the entire population, identify needs in advance, and ensure the right type of care is offered, with a specific focus, again, on prevention, wellness, and underutilization. Historically, these three things are the drivers of disparities and poor long-term outcomes. Additionally, as part of our quality strategy, we are launching bold goals 50 by 2025. The 50 by 2025 will include focused initiatives around children preventive care, behavioral health integration, and maternity care, really with a focus and a stratification based on health equity within these domains. These priority areas are embedded in everything we do, from our value-based purchasing strategies to our metrics that we're monitoring and to our health equity roadmap. If future Californians are to have longer, healthier, happier lives, our quality and equity strategies must address the foundations of health. Really those preventive efforts that have long-standing impact from birth to our seniors. And we want to really move the mark on some of these chronic diseases that result in long-term poor health outcomes. Now moving on to our managed care procurement and our new managed care contract. California relies on our Medi-Cal managed care plans to implement the state's responsibility to provide Medicaid services. As such, we must insist on partners that are committed to this charge. Our plans are our critical partners in implementing our vision for Medi-Cal. In February, we released a request for proposal for our commercial Medi-Cal managed care plans, formally launching our first ever statewide procurement. This new contract will go into effect January 1st, 2024, and will apply to all of our Medi-Cal managed care plans. This is really a unique opportunity for this state to install new and enhanced requirements on our plans, where 99% of Medi-Cal members will receive their care by 2024. The new contract will be the main vehicle by which we will ensure health equity, quality, access, accountability, local engagement, and transparency from all of our managed care plans. Through this contract, we are really embarking on a new relationship with our plans to redefine how healthcare is delivered, what is health equity, what are healthy communities, how to better hold the healthcare delivery system accountable, and ultimately how the state achieves a healthy California for all. Partnering with managed care plans that meet or exceed these requirements amplifies and strengthens the state's recent investments in the Medi-Cal program. With CalAIM's opportunity to transform our program, our comprehensive quality guiding us to achieve better health outcomes, and our new managed care contract, we are at a pivotal time for the Medi-Cal program. We are pushing outside of healthcare's four walls and promoting better partnership and integration with other sectors, including public health, probation, social services, education, etc. This is how we will achieve our vision. We have a few other big initiatives underway that I know won't get into them in details, but I wanted just to quickly draw to your attention. Last year's budget included over $2 billion for our behavioral health continuum infrastructure program. We have 6 rounds of competitive funds to build, buy, and rehabilitate real estate assets or invest in mobile crisis infrastructure to expand our behavioral health community continuum. 3 rounds are already underway, and our 4th round will be released sometime early this summer, and that will be behavioral health continuum dollars for our children and youth facilities. We're very excited about this. In January, we published a comprehensive behavioral health assessment to understand what is our behavioral health continuum in California. We've identified some gaps, and we're using this assessment to inform our state initiatives as well as future federal funding opportunities. The report has highlighted the need for some deep investments in 3 populations, those facilities and programs that treat the justice involved, children and youth, Native American and Alaskan Indians, and so we are making a concerted effort to ensure that we are prioritizing these populations as we build out our continuum. We are also in the midst of implementing the Children and Youth Behavioral Health Initiative, which seeks to reimagine the systems that support our behavioral health for all children and youth in California. This future system will focus on promoting social and emotional well-being, preventing behavioral health challenges, and providing equitable, appropriate, and timely service for emerging and existing behavioral health conditions. And then finally, over the last few years, California has expanded Medi-Cal coverage to children, young adults, and older adults age 50 and over, regardless of immigration status. The governor's budget proposes to expand eligibility to the remaining population, those aged 26 through 49, regardless of immigration status. So beginning no sooner than January 1, 2024, Medi-Cal will be available to all income-eligible Californians, regardless of immigration status. I'm very excited about this proposal and kind of our path towards moving for a healthy California for all. With that, thank you again for the invitation to be here today, and look forward to questions.
Thank you, Michelle. Over the years, I've heard many Medicaid directors speak, and health, that is as comprehensive, complex agenda as I have ever heard. And nothing about Medicaid, Medi-Cal is ever easy. It's always complex. And in a state like California, where things are especially complex because of the financing and organization, very ambitious agenda. There might be a question. Who has the first question? I see one hand here, a microphone. Who has the first microphone? Yes. Okay, please.
Sure. Hi. I spent about 30 years of my medical career treating young adults at a college campus, and I want to talk about Medi-Cal portability and the struggles that we had about our Medi-Cal patients being able to access care when they were outside of their home county. Young adults are extraordinarily, I want to say, moving population, particularly with COVID, and a number of folks in Medi-Cal are a very mobile population, and the ability to have portability of their insurance was a major problem for them, particularly around reproductive health issues. And I'm just wondering if you could address how Medi-Cal plans to ensure that those who qualify can maintain their coverage when they are outside of their home area.
I would say I don't know of any particular efforts we have underway on that, but I think it gets to the point of coverage, the Medi-Cal program, regardless of payer source or even just healthcare, regardless of payer source, regardless of county, how do we seamlessly coordinate the provision of those services? And I think one of the specific items we have on our agenda on this is the Children and Youth Behavioral Health Initiative and a focused effort on higher education, ensuring that services are delivered to all children or young adults as they are they move across county lines or go to school in different locations, and that access to those services are available. I think the more we work on our data and the more we're able to the interoperability of the information, I think the better we will be in terms of crossing county lines and assuring that individuals have access to their information and to their providers.
Okay, who has the next question? We have time for just a couple questions before we break for the tracks. But here's a question here, yes.
So I'd be interested in your perspective on the potential demise of the federal public health emergency and the impact of that in the state.
The unwinding question.
Yes, I will say this is probably the most pressing immediate issue on our planning efforts with regard to the redetermination. I mean, we have a few things that we will need to really address. The redetermination of our Medi-Cal individuals. We've paused basically on that for the last 2 years, so working very closely with our county partners and our health plans in terms of preparing for that process, really wanting to reach out to our Medi-Cal members, saying, once you get that renewal package, please take action. Please make sure we have your most recent contact information. We're launching a DHCS coverage ambassadors mobilization effort so all of our community partners can really spread the word in terms of update your contact information, take action on your redetermination, and really thinking through the federal government has provided us some flexibilities in how we might be able to use those flexibilities to ensure that we are able to ensure, maintain coverage for our individuals or ensure transition, whether it's to Covered California or employer-sponsored coverage. So I think that is a key facet of our efforts over the next few months.
So I've heard estimates that upwards of 1.5 million people might actually lose coverage when all of this takes place. What's the impact going to be?
I mean, I think we are probably around 1 to 2 to 3 million potentially may lose coverage. We know that many of them will probably be eligible for Covered California, and come July, there's this automated process that will help facilitate that. Yeah. I think given some of the data runs that we've done too, I think individuals are already on employer-sponsored coverage, so I think it is something we are really working for, wanting to make sure individuals take action so that they don't lose coverage just because the redetermination wasn't processed. And so really working, please help spread the word on this, that we really need individuals to take action when they get that package.
Yeah, underscores the importance of that for sure. Who has the next microphone? Right over here? Yes.
Hi, thank you so much for being here. The efforts that the department has taken to improve access and equity through Medi-Cal really are admirable. But I was hoping, and I don't mean to put you on the spot here, whether you could address the new Medicaid contract with Kaiser and sort of how that potentially impacts the sort of standard and level setting that reprocurement was supposed to provide for all of the health plans.
So our Kaiser proposal is really intended to provide some of that continuity, some of the questions that were just asked about. An individual maybe is moving from one line of coverage to another line. So for example, someone has employer-sponsored Kaiser, they lose their job, they're able to maintain Kaiser coverage in the Medi-Cal program. So looking for opportunities to ensure our beneficiaries have access to high-quality care that they choose. And so I think that is one facet. Similarly, for our foster youth, Kaiser is in 32 counties. Having Kaiser as an option for our foster youth as they transition between county lines, unfortunately because of placement changes, really having an option so that there is coverage that shows, yes, they've been immunized. Yes, this is what kind of they are allergic to. We have too many instances for our foster youth where that information does not follow the youth and we have poor health outcomes. And so thinking through options to really how can we provide more for our beneficiaries, provide high quality care and increase access. With all of these things that we've talked about, we know Medi-Cal will be growing and we want to ensure that there are as many providers in our system as possible.
Okay, we have about 30 seconds left. Who has the last question? Who has the microphone? Is there there's a, well, we need a microphone. So a quick question. I'm told we have 20 seconds, so we're going to go quickly here. Yes.
Director, can you just speak a little bit about what you feel CMS will do with the waiver application on the justice-involved population? It's pretty innovative, and I know a lot of states are looking at California to lead in this and what that means for other states.
No, we're having great conversations with CMS, and I think to your point, many states are interested, so really kind of having some really tight conversations about what does this mean for the Medicaid space and what we're all trying to attempt to kind of, the more we're upfront and invest early, the better long-term outcomes, and so I think we're united in our goals with CMS on that, and good conversations are happening.
So thank you for your questions. I'm going to ask if you could just stay here for a few minutes because there were other people who had questions, and maybe they can come up and chat with you for a minute. That would be great. Thank you so much.
Thank you very much.